Good evening, and thank you for joining us. My name is Dr. John Ayanian. I serve as the inaugural director for the Institute for Healthcare Policy and Innovation, and I'm the Alice Hamilton Distinguished University Professor of Medicine and Healthcare Policy here at the University of Michigan. I'm delighted to welcome you and to facilitate our discussion for this evening's event. Before we get started with our program, I'd like to go over a few housekeeping notes. First, our discussion's being recorded today. Second, we will begin our webinar with a brief overview of the university's Institute for Healthcare Policy and Innovation, followed by an introduction and remarks from each of our three panelists. This will be followed by a discussion among the panelists and questions and answers, some of which were submitted on the RSVP form by those of you in our audience this evening. We'll also be using the Q&A function to take questions later in the program. If you have questions, please add them to the Q&A box on your screen. Our event features three experts connected not only by their knowledge of healthy aging, but also by their ties to the university's Institute for Healthcare Policy and Innovation, or IHPI for short. IHPI brings together more than 640 faculty from all three University of Michigan campuses and from a broad range of fields. Together, we make up the nation's largest university-based group of researchers focused on healthcare and healthcare policy. And the grants that fuel much of our research account for 10% of all of the university's research spending. IHPI connects our faculty members to one another and to the resources they need to improve the quality, safety, equity, and affordability of healthcare. Healthy aging is a policy priority for IHPI. Our faculty study a broad range of topics related to healthy aging. In addition, IHPI is the proud host of the National Poll on Healthy Aging in partnership with AARP and Michigan Medicine. The National Poll on Healthy Aging is a nationally representative survey which aims to inform the public, healthcare providers, policymakers, and advocates on issues related to health, healthcare, and health policy affecting adults ages 50 to 80 and their families. This evening, you'll hear from Drs. Julie Bynum, Preethi Milani, and Donovan Moust. Dr. Julie Bynum is the Margaret Turpening Collegiate Professor of Internal Medicine and Professor of Geriatric and Palliative Medicine. She is the Associate Director of the Division of Geriatric and Palliative Medicine. Her work focuses on health system performance for an aging population, in particular those with high needs or cognitive impairment. She strives to find new ways to use data to inform better healthcare delivery, payment, and policies. Dr. Preethi Milani is the university's Chief Health Officer and Professor of Medicine in the Division of Infectious Diseases. As the university's Chief Health Officer, Dr. Milani serves as an advisor to the President on matters of health and wellness for the university community, including disease management, public health preparedness, and promotion of healthy practices and climate on all three campuses. Her work focuses on infection control and prevention of infections in older adults. She's the director of the National Poll on Healthy Aging based at IHPI and also an associate editor of the Journal of the American Medical Association. Our third expert this evening is Dr. Donovan Moss, associate professor of psychiatry in the medical school, specializing in geriatric psychiatry. His work focuses on what drives overuse of medical care, psychotropic prescribing in particular, for older adults. Prior to our conversation, I've invited each of our faculty members to share a bit more about themselves and their work, including why they were drawn to the University of Michigan and to IHPI. We'll start with Dr. Julie Bynum. Dr. Bynum?
Good evening. Thank you, John, and thank you everybody for joining. I am, as John mentioned, a professor in internal medicine. I'm also a co-vice chair for faculty affairs here at University of Michigan. In addition to that, I just arrived 2.5 years ago. So it's been an exciting time for me here. I want to convey to everybody one of the really important key features of what University of Michigan has brought for me and why I chose to come here at this stage of my career. I have spent my career studying how we can make sure older adults get what they need and what they want from the healthcare system. And that sounds fairly straightforward, But really, when we think about older people and as our lives change, we have new and special needs that are different from when we were 30 or 40. And meeting all those needs are complex. The healthcare system itself is complex, but we also have things like people in the community needing support, long-term care. Then we have this amazing group of baby boomers who are healthier than ever. And how are we going to really keep them healthy? So when I looked around, John asked, why did I come to University of Michigan? I'm deeply aware of the complexities that it takes to maintain a healthy older adult population across social policy, medical care, public health, environment. And when I looked around, there were very few places that had the depth and breadth of expertise to address the full spectrum of what it takes to have a healthy aging population. And in particular, for me at least, IHPI had already drawn together the groups of people who are very important for my work in studying what we could do in the healthcare system, how we pay for it, what kind of social policy we use to try to advance the care of older adults. And on top of that, I'm deeply invested in raising the next generation of scientists who are going to make sure that I stay healthy and well as I age. And so equal investments of the next generation of scientists. Just in brief, I have a robust NIH-funded research portfolio and recently was awarded one of 2 new centers for population research and Alzheimer's, where actually Donovan Maust is also participating in that. And we're really excited to be able to provide an on-ramp for people who want to enter the area of studying how to better the lives of people living with dementia. So I'll turn it back to you and hear from the other people on the call.
Thank you, Dr. Bynum. Next we'll hear from Dr. Preethi Milani.
Hi, good evening. And thank you, John and Julie. It's a pleasure to be here. So I actually was born and raised in Michigan, and I had the really great fortune of attending the greatest university in the world, the University of Michigan. And I've actually pretty much stayed here most of my adult life. I've been away. Ironically, one of the places I was away was for my geriatrics fellowship on the West Coast, but I'm a born and bred Michigander. And I've actually had a lot of different types of activity here over the years. I feel like I've had different careers. Right now, my clinical work is infectious disease, but I am trained in geriatrics, and in the past, I was very involved with clinical care in that area. And for me, I'm relatively new to IHPI. I guess I've been a member for 5 years in the sense that I was like a grown-up in the academic world when I joined. And I can't even have imagined really how helpful the experience has been for me. I came on really with no expectations, just this idea that these are people who are interested in some things I'm interested in. And I was very fortunately tapped to help start up and run the National Poll on Healthy Aging, which I direct along with a wonderful team of individuals. And we'll probably get an opportunity to talk a little more about that. For me, I'm a little bit of a misfit in the medical academic world, where I'm not quite clinical, I'm not quite research. I love to write, I love to solve problems, I love to talk to people. Some of the things I'm working on right now, to be honest, my life has kind of been busy with COVID this year, not just on campus and clinically, but also thinking about older adults and how they've been affected disproportionately, not just medically, but the fact that many are very isolated, that they're lonely. So these are some of the things that at a policy level are really important to really all of us. Caregiving, which is affecting so many families right now. I feel like IHPI has sort of been this just amazing gift to me. The kind of conversations that happen, right now they're happening virtually, of course, but the types of discussions that happen there, I don't think they can happen anywhere else. And the work coming out of IHPI really reflects that. It's truly, truly a place that there aren't any silos, that anyone can be anyone. And I think that is a wonderful thing for me. It's a really wonderful thing for people at every stage of their career. Looking ahead, we plan to continue the work with National Poll on Healthy Aging, which I hope I'll get a chance to talk a little bit about during the conversation. One of the other things has been the partnership with AARP that has been very beneficial for us with the poll, but really helping all of IHPI think broadly and actually take some of those policy messages and help elevate them. So I'm gonna end there and hand it back over, and I look forward to a really great conversation today.
Thank you, Dr. Milani. And now we'll hear from Dr. Donovan Moss.
There we go. Thank you, John. It's a pleasure to be able to join you all this evening and to follow Dr. Bynum and Dr. Milani. So I'm an associate professor of psychiatry here. I'm a geriatric psychiatrist, and I did my residency and fellowship training at the University of Pennsylvania, and was not sure that that's where I wanted to stay and start my faculty career. And so when you're an early career faculty member, it's really important, if you want to kind of launch a research career, to be in a place where people have expertise in your field. And in late life mental health, there aren't too many places where you can find that. So interestingly, the two places that I was seriously considering were Dartmouth, largely because of the opportunity to work with Dr. Bynum there, and the University of Michigan, which has an incredibly productive and successful group of mental health services and policy researchers. Ultimately, I'm actually originally from Michigan, moved away to Virginia, but still have family here, grew up in a college town, and just felt both for my career and for what our family was looking for, Ann Arbor and the University of Michigan was the right choice for me. As part of that interview process, it really stuck out to me that John Ayanian, the incoming director of IHPI, who at that point was still in Boston, actually took the time to have a phone call with me as I was making the decision. And that frankly was really remarkable, that this academic big shot was willing to take the time to talk to this lowly geriatric psychiatry fellow who was looking at the University of Michigan. And I think that approachability of sort of research and policy luminaries, that's just the nature of the University of Michigan, which is why it's been just such a remarkable faculty home. I really had no idea what a good decision I made at the time, but in retrospect, it was just an amazing decision. And really largely, I'd say, because of IHPI. So when you're not a University of Michigan lifer, it is an overwhelmingly huge place. And while that has tremendous advantages and benefits, when you're a newbie, it is pretty overwhelming. And the remarkable thing about IHPI is sort of it reduces 6 degrees of separation down to just 1 or 2. And it only takes you a connection with 1 or 2 people to sort of find who you need, which is really amazing, because for sort of whatever your research idea is, the person that you need to connect with is at the University of Michigan, and you can almost always find them through IHPI. I've had the pleasure of being involved in the early career faculty advisory committee for IHPI because John and Gail Campanella, who run IHPI, really very seriously wanted early career faculty input and to understand how IHPI could better help early career faculty. And just the resources are really tremendous. It's just been a really incredible place, and I'm always feel very fortunate and grateful to have been able to start my faculty career here. And I'll pass it back to John.
Thank you, Dr. Moss, and to all 3 of our experts joining us this evening. We now want to shift into our question and answer and group discussion period with our panelists. We encourage you joining us this evening to add your questions in the Q&A window at the bottom of your screen, and we hope to get to many of the questions that you may have. We have some that were submitted in advance, as well as some topics that our speakers were particularly interested in addressing this evening. And one that was mentioned in the introductions by you, Dr. Milani, was the National Poll on Healthy Aging. And I wonder to start us off, if you could say about how this shapes the work of IHPI members and what impact it has on the people that we present our findings to and the partnership that we have with AARP.
Thank you, John. I would love to talk a little bit about the poll. So this is again, I think a good example of the magic of IHPI. And I guess it was about 5 or 6 years ago now, there was a lot of discussion around what health policy topics would be important and impactful in the coming. Aging really rose to the top of that discussion, and those discussions eventually led to the National Healthy Aging. This is a national household survey that is recurring, and it is not just about health. It's about health and healthcare and health policy. It's really about what happens every day in people's lives, and really goes beyond the traditional medical issues to get at overall well-being. And for the purposes of this poll, we're not interested just in aging, but pre-aging. And so we look at older adults from 50 to 80. I'd encourage all of you to look at our website, healthyagingpoll.org. And, just to give you some examples of things that we normally wouldn't do as research projects, one of our most recent polls was on ageism and the idea of what ageism might do for health. And again, not really a traditional topic that people are going to run and do research on, but yet so impactful in terms of what happens in people's day-to-day lives and what might happen in terms of their health. The pandemic has changed so many. We seek healthcare, and telehealth is one example. And so that is our most recent poll. And if you stay tuned next week, we're going to have a really interesting poll on loneliness and social isolation. And it'll be sort of looking at a follow-up from a previous poll done. And of course, the pandemic has added to those issues.
Thank you, Dr. Milani. And I wonder if we could turn to one of the questions that was submitted in advance by one of our attendees regarding what supplements, botanicals, or foods they help improve and maintain memory and focus, and in what doses or quantities. And actually, by a great coincidence, this is a topic that Dr. Moust worked on with the national poll. And so I wonder, Donovan, if you'd like to share your thoughts about that, and then we can turn to Preethi and Julie as well.
Sure. So the unfortunate and pretty easy answer is there's sort of a good dose that has been shown to have benefit of supplements, vitamins, to help protect memory. That is, I think, disappointing to some people. That it's also slightly concerning because we know lots of people actually use those. So I had the chance to work with Dr. Milani on developing one of these national poll modules where we specifically were interested in how concerned are people about the likelihood of developing dementia, folks who are in midlife, so 50 to 65, and then what kinds of things people in that age range doing to help prevent dementia. And so one of the things that there's actually the very best evidence for is actually managing your hypertension. So what we would have wanted to see is a lot of people saying that they had talked to their doctor about managing their hypertension. And actually very, very few people reported that they were having a discussion with their physician about trying to prevent dementia. On the other hand, we asked questions about taking vitamins, taking ginkgo, playing memory games, and many people, like say something like half of respondents, endorse some of those strategies. And unfortunately, there's just not really any evidence that those help people protect and preserve their memory. So again, the short answer is supplements won't help, but talking to your doctor about managing your blood pressure actually will, and it's really, really important.
Hey, Donovan, can I
Please.
build on that? Yeah, build on that a little bit. So one at University of Michigan, I do primary care for a geriatrics clinic. I also position in an early cognitive symptom clinic. We're evaluating people who really aren't functionally impaired, but are worried about their memory. And I have this conversation so many times with people where I have to say, it's kind of painful, but I have to say, there's not good evidence that supplements, just you said, help. I can't tell you that I know that they harm. I do know they hurt your wallet. So I think there's some balance here that people people sometimes seem willing to invest their money that might be used better on a gym membership or on something for a pill. And that's a little bit of an attitude that we sometimes share, where we're looking for the pill to fix something. And in this case, for cognitive impairment, it's going to be things that are good for your heart. It's going to be blood pressure. It's going to be exercise. It's going to be social engagement. I know Preethi has a lot of feelings about that too. Mean it as a negative message, like, oh, that doesn't work, don't do it. But it is that there are that will help. And let's try to put our attention toward those.
That's a good segue to another question we received in advance from one of our attendees, and that is, what lifestyle changes are most beneficial for aging? And do you need a geriatrician for your medical care? Dr. Bynum, you were trained in geriatrics, as well as Dr. Milani. I'd be interested in your thoughts about those questions.
Yeah, so the basic story is, if it's good for your heart, it's good for your brain. If it's good for your heart, it's good for your function. I mean, I think all those things, walking, exercise across your lifespan. I think one thing physicians won't be good at telling you is that they don't generally see the healthy older adults. Anybody in training, they see the, really sick ones. We see people in the hospital and clinic. But so Donovan, I chuckled when he referenced Dartmouth. So I came to University of Michigan from Dartmouth, which is in the mountains of beautiful Vermont. And one of the things I noticed was the extraordinary number of very old, very healthy skiers. People who had spent their entire lives hiking, skiing, and then come to me at age 85, still hiking. And I think that speaks to the lifestyle. It's not just a change right when I turned 70, it's sort of having a lifestyle of activity. In terms of the geriatrician question, I see in the Q&A, somebody has asked, why are the numbers of geriatricians shrinking, not growing? The truth of the matter is, clinically, geriatric medicine is not sexy. We're not doing magic, we're not being big cures. We're not saving children from cancer. And it's hard to get the attention of people, because a lot of people want to look away from aging. They don't want to acknowledge. So it's just, for physicians, it's just not the cool thing to do, one. And then there's the financial things. It's, it's a field that's paid by Medicare, which pays less than, so, salaries are all lower. So those things together make it a less attractive field in general. But that said, my objective is that every physician, maybe aside from pediatricians, really needs to know how to take care of older adults. And my role as a geriatrician, and Preethi's and Donovan's and geriatric psychiatry, is to train everybody else to do it well, because there's no way, I will take care of the most complex. That's what I'm good at. But the healthy older adult, they don't need me. So that's how I would answer that question. I don't know if Preethi has another viewpoint on it. But.
Yeah, it's Julie, very wise as always. I would add a couple things around the well-being piece. We tend to think about well-being as medical health, but we should look really broadly, like the SAMHSA model. So it's like social, emotional, environmental, spiritual, occupational, like all 8 domains. And I feel that social engagement piece is something that I've always seen. I used to have this belief, and Julie has told me that this isn't exactly true all the time, but that if you got to 90, you were like generally a cooperative, happy person because like people around you loved you. And like, it's just something I noticed, that a lot of the patients I saw who were really far along, like 100, 90s, that they tended to be ones that just had a lot of love around them, and they had a lot of love themselves. I felt like, you sort of died of bitterness earlier, if, and again, not scientific, but I do think that social engagement, and that's one of the many tragedies of the pandemic, and particularly people who are living in retirement communities, that they are separated. And I just wanted to second what you said about geriatrics. I was so fortunate to do a geriatric fellowship. I'm of course that's not my primary specialty, but I really viewed it as learning a second language, learning a new language, and just being able to communicate with all kinds of specialists and to really think about patients in a much more holistic way. And I continue to bring that to my care. So we can definitely infuse a little bit of geriatrics into all types of care.
Donovan, we've touched on some of the issues of mental health, but I wonder sort of what your perspective is on, as a geriatric psychiatrist, what can we do to maintain people's mental health and social engagement, well into their later years? And how does the medical system play a role, but also elements outside the medical system?
Yeah, I mean, so I think in some ways the things that protect your brain from the sense of protecting you from getting dementia also are protecting your mental health and your emotional health. So I talk with folks about activity in 3 domains: physical activity, social activity, and intellectual activity, and the extent to which you can engage and preserve across all 3 of those things is really valuable. Julie made a good point about how sometimes I think in healthcare settings where trainees in particular can, when you see the sickest of the sick and your typical patient is an older adult who's ill, you forget that there's a whole world of healthy older adults out there. So I do a lot of my research is on prescribing and overprescribing of psych meds to older adults. And I think, frankly, it's a little bit ageist. And when I talk to students, I think there's this idea like, well, of course people are on antidepressants. It's depressing to get old. And I point out like, no. And in fact, when you look at epidemiology and you look at past year, like how common is major depression, depression with a capital D, among all adults, it's lowest among those who are 65 and over. And so there are plenty of older adults who are really doing very well. They're just not necessarily the people that we're seeing in the clinic or in the hospital, which is also why I find the area of medication use and overuse so interesting, because so then why are more than 20% of older adults being prescribed antidepressants when actually very few of them have major depression? So I think part of it is fighting against what oftentimes we see in the media, frankly, around sort of narratives around aging and aging being bad, when in fact there are plenty of people out there who are doing really very, very well.
Yeah, and the other part, Donovan, that you bring up of a lifestyle is attitude. I think Preethi talked about this, touched on it too, but it's an adaptable attitude.
Yeah.
Right.
Yes.
That like, yeah, I talked about these people who are still hiking in their 80s, 85, but they're not doing the big mountains. They're doing the smaller ones, and they're still loving it. They're enjoying it. They're adapting what they do to what their current capabilities are. Even as our capabilities change, they don't stop. They just adapt. And I think having that adaptability mindset, I know people, that's a literature out there now about mindset, growth mindset and things. I think that's one of the features that helps us age well.
Yeah, I definitely agree.
I think you're, in a way, if I can just add a comment, you're talking a little bit about resilience and things, Julie, and I was sort of struck. My other hat is, of course, as the university's chief health officer, and right now I'm thinking a lot about our students. They're coming back and campus is different. We think about loneliness in older adults, and again, our prior work with National Poll on Healthy Aging indicated about a third of people felt like they were lonely, that they lacked companionship. And again, you'll have to tune in on Monday when our next poll comes out. Those numbers have gone up a little bit with the pandemic, and again, for some obvious reasons, but those numbers are nowhere near the numbers of college age students who say that they're lonely, where the numbers are in the 60-65% range. If you look at the National Collegiate Health Assessment, and again, I find those stunning as a parent of a college student. It makes me sad that people have that loneliness. And so I think it's interesting where, and maybe as I've gotten older too, like you do appreciate all those abilities to do things, and there's that resilience piece that goes with it.
One of the questions we've gotten from our audience this evening is why the National Poll on Healthy Aging assesses opinions of those up to age 80. And I want to emphasize our research in the Institute as a whole goes, throughout the lifespan from birth to people's final years. We don't have an age cutoff, but in our National Poll on Healthy Aging, we do focus on adults ages 50 to 80. Can you describe the thinking behind that decision?
Yeah, sure, John. And it's a great question. So we are interested in people who are in the community, that they are, sort of aging, pre-aging, they're thinking about retirement, maybe they're well into retirement. And sometimes with some modules, we actually are interested in the younger group, like the 50 to 64, people who are working, people who may be caregivers to older adults. And sometimes we're more interested in that 65 to 80 group, and sometimes across the spectrum. Part of this is just a practical thing, because we don't have a lot of people in the sample that are above 80, and so it becomes a little bit less representative. We have thought about using older than 80 if the right fit comes along, but so far we have really focused on that 50 to 80 because we really do want to look at a healthier population, and sort of what Julie described, like sort of the people maybe who don't come and see her but are hiking in the mountains. Those are the ones that are the target of our poll.
Thanks. Another question we had from our attendees in advance was, how can we best balance the social and emotional needs of adults in long-term care facilities with the need to keep them safe from COVID? And a lot of nursing homes have cut back on their visitation policies. And, obviously in the early days of the pandemic, it was to minimize people becoming infected with the coronavirus. But now that we're coping with this, in the long term, it's been in the country for over 6 months now. How do we think about the role of long-term care and the needs of residents in long-term care facilities? Julie, maybe you could start us off on that with your experience.
Yeah, so this is an area of very active research for me, my mentees, my colleagues, particularly at Brown, where we have a very extensive research network. We're doing real-time studies in nursing home using electronic health records real-time from nursing homes, and I have all the nursing home data for the state of Michigan, so there's a lot going on here. The question, though, I think puts right at odds the really difficult things of being in a nursing facility that Preethi's already mentioned, and Donovan. We know the treatments, antipsychotic use appears to be going up now because behaviors are worse for people living in nursing homes because they're not getting the inputs they normally get, those social interactions. And what's the quality of life trade-off that we're making here? Those are deeply distressing issues. And finally, I would say many of us have been worried about this particular issue, loneliness, social isolation, for a long time, and it's finally come to the fore. So one thing to say is now this is front and center issue. How do we treat older adults? How do we engage them in our communities, in nursing homes, is now front and center. So the trade-off to me has two parts. First of all, the population of people who reside in a nursing facility are intensely vulnerable from a health status point of view. They are the most fragile. But there's another population who's highly vulnerable that reflects the complexity of nursing home care. And those are the mostly women who provide hands-on care in these facilities, the actual workforce. If you look at the population of people who are direct caregivers, the people who feed our mothers and grandmothers, change the bed, get people dressed, transfer to the bathroom, those people are earning minimum wage, very likely uninsured, very large majority are actually from minority populations. And there's incredibly high turnover for that population because they can get better pay and better benefits working in the fast food industry. So when we think about how to address the social engagement and safety and the trade-off, I think we should be thinking about the workforce there as well. If we can keep them safe and engaged so they can continue to be the care support for those people living in the facility, we'll be in a lot better place. Certainly transmission rates have dropped precipitously in the nursing facilities. At least that's what we're seeing in Michigan, as people have PPE and all sorts of other capabilities, and testing, very frequent testing, because those same workers are going from facility to facility and are the actual vectors often for infections. So I think it's a two-pronged attack. It's keeping the individuals safe, letting those individuals continue to have safe contact with their family members, and then also working with the workforce so that they want to stay in these settings working and can be safe themselves and provide some of the social engagement that maybe less family contact is leading to isolation from.
I might
Preeti
just,
or Donovan? Yeah.
yeah, I might just add on to Julie's outstanding comments around the vulnerability, the dual vulnerabilities. And if you look at how COVID actually really took off, it was in nursing facilities, particularly in the Northwest in Seattle. And it was employees coming to work ill. And, you know, I think we've made a lot of good progress. One of the things I've been involved with the last couple months, Governor Whitmer named me to the COVID-19 nursing home task force. It's actually one of 2 physicians. And the rest of the task force was people like really on the ground advocates, people working in the nursing facilities. And, you know, it was really like a robust discussion. And we actually provided this big report to the governor actually a couple weeks ago, and it was presented just a few days ago. And some of the things around hub facilities and testing, and you know, the hope is we're not going to see the kind of surge that we had in the spring, and we're doing our best to protect vulnerable communities, but that we can get to a place where it's not reckless to have visitation and to have it in ways that are as safe as possible, because there is this secondary issue that happens, and people end up in their rooms. They can't leave. They get debilitated. They fall. They break their hip, and then they die not of COVID, but they really did die of COVID in a sense. So this is one of many tragedies that is related to this, and I'm hopeful. Testing doesn't actually give us the things that we think it might, in the sense that like we can't test our way out of the pandemic, but in a nursing home setting, we probably could do testing to allow families to at least come in and visit their loved ones. And they're not just visiting, they're often doing really critical care. So it's essential that they're there.
Yeah, and in that role of family, I know I am personally struggling with having, you know, my older parents, to think of myself as a harm to them, a potential risk. And I think a lot of us are struggling with, we don't think of family as harmful. They're always good, but I try to assume I've always been exposed, and therefore how should I behave when I'm dealing with one of my patients or my parents or something like that. And so it's the other population this is related to, or it's just not just in the nursing home, are more frail older adults who live in homes they can't get out of. They're receiving long-term care in the home. How do we interact with them and keep them safe as well? I think it's a very much the same issue. Except it's our family members coming in and out more than it is paid caregivers. It's a very similar issue.
So another question we have from our audience is, are there lessons from COVID that will change care for the elderly? And that could be, you know, different important groups of elderly, those in nursing homes, those who are homebound, receiving care services at home, as you mentioned, Julie, and those who, you know, are relatively healthy and independent, or, you know, living with chronic illness, but in a manageable way. Are we learning anything from the COVID experience that may persist even once we have a vaccine and life gets somewhat back to normal?
Hand washing works. Preeti, that was for you.
Yeah, no, hand washing does work. Well, the thing, John, that came to mind for me was really the telehealth issues.
Yeah.
And that, you know, they're actually, and again, we looked at this a year ago in the National Poll on Healthy Aging, and then we actually repolled on it. And it was sort of a theoretical issue a year ago where very few people were even aware of it. It was more like, would this be of interest? And then all of a sudden, you know, within days, complete pivot, and people had to do this. And, you know, the things that we found is that you know, it went okay for, especially if you had an established relationship with someone. But, you know, I'm thinking about things like, there are not that many Donovan Mouse out there in terms of geriatric psychiatry. And could you bring that capacity to people in places where there's not care? And again, there are people at IHPI who are doing this type of work, this idea of specialty access. So I do think telehealth is going to be one of the things that does continue, especially for older adults. One of the things in the nursing home we talked about in the task force was the idea of specialists and consultants coming in there. So physical therapists and other people who, you know, you ended up in a situation where you weren't necessarily getting all those therapies. You know, podiatry is another one that's really big. And when the limits were there on anyone coming and going, you know, telehealth could help fill in some of those gaps.
You know, the other thing that I think telehealth is huge, and actually I thought you were going to say, one of the reasons we stopped at 80, a lot of people assume people over 80 don't have internet access, which is plain silly and wrong, right? We know that not to be true, and telehealth is lots of older adults have access to internet. But I think putting the social isolation issue on the map, one of the things, I sit on a committee, a forum for the National Academy of Medicine called Aging, Disability, and Independence. And one of the concepts we've shared a lot there is that good design is accessible design. And I have had in my primary care practice, it's been astonishing. I say to some of my folks, so how are things going under COVID? I know this is stressful. They'll like, actually, this is the way I always live. And now I can actually go to my church services because they're online. We're having Bible study remotely on Zoom. I'm having 80, whatever-year-old telling me they're more engaged because the groups they engage with are now making an effort to provide ways to access that are outside of the norms of in-person face-to-face, and that improves accessibility for everybody. So I'm hopeful that creative sense of how to bring people together has potential for us, and the use of technologies more generally.
Donovan, when I see the statistics from our Michigan Medicine health system, the university's health system, psychiatry is really leading the way on telehealth and virtual visits, I think in part because your department had a head start and was thinking about, for example, how to serve the mental health needs of residents of Michigan in more rural areas that may not have good access to mental health professionals, including psychiatrists. So can you sort of reflect on the experience, what you and your colleagues have learned about using video visits and telehealth during COVID-19 and what's persisting over time?
Yeah, so you're right. Psychiatry, I think, had sort of a head start in telehealth, and so was ramp up. And a lot of ways were perhaps the specialty most suited to be able to be delivered by telehealth. I think in particular for older patients, where frankly, sometimes just getting to the physician can be a real ordeal. And so to be able to do that from your own home, in the privacy of your own home, is frankly a real benefit. And so I hope that some of, say, the sort of payment and policy rules around telehealth have been relaxed during COVID. And I think there's a hope that they will stay that way to make it easier, that reimbursement will be similar compared to an in-person visit. I think the other place that has always been ahead of the curve with telehealth is the VA. And they have been, so I actually provide my clinical care in the VA, and they have transitioned almost all of their outpatient care, or as much as they can, to telehealth. Specialty services have largely been available by telehealth because so many VA patients are in rural areas. And so they have even been very providing patients with the technology and the ability to use telehealth if they don't have the means to have those tools on their own. So I think in general, those of us in mental health we're not pleased that it took a pandemic to expand telehealth, but I think for a lot of patients, it's actually been a very welcome opportunity to engage with their providers, frankly, much more easily.
That leads to another topic that was raised in advance, which is the role of technology more broadly in helping people to age in place, as we say, to stay in their homes for as long as possible, ideally for all of their life. And what is the role of housing policy and technology in supporting those goals that most people in our society have, regardless of their background?
Everybody's chomping at the bit to answer that one. Again, through this wonderful community that I get to participate in, it's a mix of the disabilities group and the aging scientific community. I've learned a lot about this issue of technology. And a lot of what's been originally are mostly like supervision, watching people, triggering whether they, you can know whether they fall or not. But there are a lot more sophisticated kinds of tools that are out there that now allow people to make sure medications are given, allow communications and other things. And then there are even technologies like pet robots for social isolation, which to me, when I first heard this notion, I was very concerned about. I thought it sort of dehumanized older adults. But in the context of COVID, I think I've maybe softened a bit, because maybe something is better than nothing. But certainly lots of people, there are now navigation technologies. So a blind person can navigate in a shopping mall. Well, that actually is probably helpful to an older adult who can't interact with vision or hearing very well with mapping devices in a building. So there's many opportunities for technology across lots of domains where people are thinking about. I mean, business, I will have to say, it's also industry and business is doing this a lot more than academics. It's a rampant field of investment in the business world.
Which I think is all the more reason why we need good partnerships with academics and universities to evaluate, these new technologies that are being developed and understand which ones are beneficial and which ones may not be worth the cost or the time required to implement them in the community. Donovan or Preethi, anything you would add that you see as being important either in the present or future as we think about technology and helping people to age in a healthy way at home?
Yeah, I'm just thinking about those robots that go all over Ann Arbor to bring food and other things, right? Like, I just think that the sky's the limit in a way, like to Julie's point, with the pandemic, we all of a sudden had to really rethink, and things didn't have to be perfect to try them out. And, whether it's grocery delivery or medication delivery, or it's virtually bringing in somebody into your home, those are all things on top of things like inclusive design. And one of our partnerships actually in architecture, and a couple of our the IHPI, in fact, the whole team, Erica Solway, as well as our AARP colleague, Alison Bryant, they actually participated in an inclusive design competition. And of course, the pandemic changed it a little bit, but I love the idea that our students are thinking about this and thinking about whether they're engineers or architects or they're in the health sciences.
Even the fashion designers designing clothes that can be put on when you can only use one arm, for example. Like, how do you design clothing for people as they have disabilities or limitations? It's really across the full spectrum, and why a place like Michigan that has architecture, has public health, has engineering, is a place that has incredible opportunities for being creative and innovative across the full spectrum of what it takes to age in place and age well.
Yeah, I guess I was thinking even simpler, and just like what having one of these things means for the pandemic now compared to if it had happened 10 or 15 years ago. I mean, so thinking about those like social, intellectual, and physical engagement. You can, if you couldn't go to the gym anymore, there's an app you can get for exercise. There are tons of online courses, many offered by the University of Michigan for free that you can take. There's like, Julie, I chuckled when you talked about the Zoom Bible study. My mom is like, her Bible study, her church group, Sunday school, they meet on Zoom now. And so just like I frankly think that the ability to tolerate and make it through the past 6 months has been so enhanced, fortunately, by like a technology that many of us are fortunate to be able to have. So nothing fancy, no pet robots, no like robot cars delivering food, but it's made a big difference.
It raises that important issue, though, those people who don't have something like a smartphone.
Right.
I mean,
or good internet access. We often talk about the digital divide and how by income or race or ethnicity or language status, people can have very different access to some of the technologies that others of all ages may take for granted. And and that's
right.
One of the issues that many of our faculty within IHPI are very much focused on is how do we promote equity in our healthcare system. And a lot of these issues that we're discussing, it's very important to ensure that these advances are available equitably to people of all backgrounds, and that we have ways to support them.
Yeah, I've mentioned the state data for nursing homes, and you think about lots of families are visiting with their loved ones in the nursing home through a Zoom. But what about those family members who don't have that? It is the ultimate of isolation. I'm colleagues with someone who is in that situation. They can't use the device to communicate with their mom in a facility, and how heartbreaking that is for everybody. But that's not just because somebody's blind or deaf. There are actually economic reasons that some people aren't able to do that. It's really important for us to keep in mind.
And that coincides with another question from one of our attendees, and about the role of safe, affordable housing, because housing is such a critically important part of people's being, and affordability of housing, especially as people get older and maybe living on a fixed income and have greater need for support in the home, either where they live or moving to a place where they can get more support. So how do we think about housing policy as part of the broad view of health and healthy aging?
So I'll just start from not so much a policy perspective as from just as a clinician providing care. One of the most valuable things is either if yourself, or you can say take advantage of the Michigan visiting nurses, or like a home social worker or home physical therapy visit. You can just learn a lot, and it's really important context to help understand the environment that your patient is living in. Thinking about things like fall risk, thinking about, so as a psychiatrist, seeing somebody with behavioral symptoms, a lot of that actually can be related to sort of all the environmental stimuli that they're receiving at home, and to have a lens in the home, even perhaps through a telehealth visit, if you have even just a little glimpse or window into the world of your patient, I think can be really valuable and help inform their treatment.
Yeah, Donovan and I both trained at Hopkins, right, Donovan? And so there was a very robust home-based primary care geriatrics practice. And it was the most humbling experience of my life to go into homes that were, the hounds around them were boarded up, and they waved you in to keep, no, please don't drive away, come in the house. And then you'd find this amazingly disabled person in this community and in terrible circumstances. And you just think, the issue here is not whether they're overprescribed. Their issue is they need to eat and be fed and be safe. And that really takes it out of the medical realm, right? I think, we are talking to 3 physicians, and where I really need my partners in schools of social policy.
Social work. Yeah.
And because those are incredibly challenging social determinants that the healthcare system, medical care system, isn't going to fix. We certainly can help bring it to table. There's another interesting group of people that, in terms of people who need long-term services, so they already have housing, but they need more support. People who are on Medicaid, we usually can get them support. People who have assets, they can pay for their own support. But there's this interesting group of people who make too much money to get Medicaid, but not enough to pay for their caregivers and support in their home. And Donovan, I don't know if that's your experience, but they're like the hardest people to manage, because you can't get support either out of pocket or from Medicaid, and they have terrible, terrible, difficult problems accessing services. So it's sort of not the group you'd expect, I think, to have trouble economically.
I know that there have been some studies in Canada around, and again, they're younger adults, but just the idea of safe housing and really how it improves health. And the one that I'm thinking of, it was actually a randomized trial of individuals who had emotional and mental health issues, and this idea of early housing and the dignity of that, and what happens health-wise, and that with a single payer system like they have there, that they were able to really recoup those costs. And I think this is one where geography probably matters and states matter in terms of what they can put in and what the appetite is to put in. And Julie has a lot of expertise in this, but from a Medicaid standpoint, people want to be at home, and it's actually cheaper to be at home, and it's better outcomes to be at home. So that may be a place where there's an appetite to try and come up with policy solutions once people are done dealing with COVID.
Well, on that note, we're nearing the end of our hour. I want to thank our panelists and all our attendees for participating in tonight's discussion. I'd like to remind everyone that this evening's event has been recorded, and we'll send out follow-up information to share with others who could not attend. Those of you who have been following the chat box will see our colleague Kara Gavin has been posting lots of resources available on the internet through the IHPI website and our National Poll on Healthy Aging website, which I encourage you to read if you're interested in learning more, and to follow us on the IHPI website for updates on many of the topics we've been discussing this evening. So thank you to everyone for your support of IHPI, of Michigan Medicine, and the University of Michigan, and go Blue.